was built to last. When the webs are weaving, I could change the past. With all I'm achieving, now I feel.
Hello everyone, welcome back to another video on the channel where we go through only high yield educational objectives, everything that gets tested all the time on ABIM, and we create our own ABIM questions that will only test high yield information that we need to know for the test, and we can test and retest and do better every time. Thank you so much for being here. We're going to cover today the ABIM for neurology. And these are the questions that I've created using GPT-4o with my own instructions on how to create these questions. And basically, we go through the questions and answers. We go through the way I have asked it to analyze it for us. This way, we're going to retain all of the presentations and the educational objectives very well, because you have to be able to apply the knowledge on your day of the board exam. And you need to recognize the objectives very fast, because the questions, come with a lot of fluff. So let's go ahead and get started. Stay with me till the end of the video. We're going to talk about how you can access the notes from the sessions. Okay. All right. So let's go ahead and get started. So this is a 65-year-old male, history of diabetes and hypertension. He presents with horizontal and vertical binocular diplopia, ptosis, and non-reactive pupil. Examination reveals a non-pupil sparing third nerve palsy. Well, on boards, they will not going to tell you that. They will tell you the presentation and what it looks like. What is the most appropriate next step in the management of this patient? So would you observe with serial neurologic exams? Would you give oral prednisone and ophthalmology referral? Would you do an MRA or a CTA? Would you do acetazolamide and lumbar puncture, or would you do aspirin and a statin? So go ahead and pause the video right here, pick your answer, and let's go through what to do about this. All right. So this is, of course, going to be an MRA or a CTA of the brain. So the third the cranial nerve or ocular nerve palsy is classified, and this is very, very high yield, classified as pupil sparing and non-pupil sparing. And this is a very, very important, both in real life and on boards. If there's pupil sparing, you can think that this is most likely related to microvascular ischemia, which you can see in diabetic and hypertensive patients. If you do have a non-pupil sparing, which means the pupil is not spared, it is strongly associated with mass effect, particularly intracranial aneurysm. Okay, and most I would say specifically and commonly, it will be a posterior communicating artery aneurysm or PCOM aneurysm. Okay, I want you to have that completely solidified in your memory. The parasympathetic fibers controlling the pupil are located on the outer portion of the nerve, making it highly susceptible to compression by an aneurysm. But that microvascular ischemia typically spares the pupil because the central portion of the nerve is affected. So the problem in the microvessels are going to be on the inside. The outside of the nerve is going to be the parasympathetic fibers that are very, very susceptible to compression. Okay, so the key clues were that this patient specifically was non-pupil sparing. Okay, third nerve palsy. He had ptosis, diplopia, fixed dilated pupil, and he did have some diabetes and hypertension, so they may throw that in. If you didn't know the sparing versus non-sparing, then you wouldn't be able to tell. And then the acute onset is also very important. Let's say if somebody this was a something that happened over time versus something that is pretty acute, so you can think about the mass effect in that. Okay, so pupil involving third nerve palsy is a red flag for aneurysmal compression and requires emergent imaging. So then the observation would be wrong. Starting prednisone ophthalmology, this would be, for example, if you suspected giant cell arthritis and you thought of some inflammatory conditions, that would be incorrect. Getting the standard, gold standard, MRA or CTA, that would be the correct answer. And then the last option, I think option D, was acetazolamide and lumbar puncture. This would be for idiopathic intracranial hypertension, and in that case you would have papilledema and not a third nerve palsy. and then aspirin statin if you were really thinking about, ischemic stroke or something like that for prevention. So when you go through the clinical decision-making algorithm, you evaluate the most importantly for pupil involvement, and if the pupil is involved, you order the MRA or a CTA to rule out a PCOM aneurysm. If pupil is spared and the patient has vascular risk factors, then it's most likely microvascular ischemia. And unfortunately, I have news for you: there's no treatment for that. You need to just treat the underlying problems to prevent progression. So that would be supportive care. And so again, it kind of goes through this pupil sparing, non-sparing, the latest guidelines. This is the 2023 AAN, American Academy of Neurology guidelines. I always ask GPT to go through the guidelines. These are all part of my instructions. Non-pupil sparing third nerve palsy mandates immediate vascular imaging to exclude the aneurysmal compression, and a CTA MRI preferred due to high sensitivity. If imaging is negative but the suspicion remains, then you may need a catheter angiography. And then the pupil sparing third nerve palsy can be managed conservatively in the presence of microvascular risk factors. And this is just kind of putting it for me because I told it that I'm going to post this on YouTube, so it's going to give me some for YouTube visual appeal. But it's not smart enough to not say for YouTube. Of course, thank you very much. So non-pupil sparing. Emergency, get that. I wouldn't say an emergency, but I would say definitely urgent. Pupil sparing, microvascular ischemia, and then never assume it's a benign. If it's an aneurysmal rupture, it could be very life-threatening. Okay. So, but again, this is a very, very high yield point to remember. Okay. So let's move on to the next question. If you've, by the way, liked this video and previous episodes, please give me a like and drop a comment, give any suggestions. If I'm going too fast, let me know. But the whole point of this is kind of like it should be kind of even like a podcast. You could listen to these on your way to the hospital. You can listen to these, on your time off, and just kind of and repetition will be the key. Keep watching and rewatching the videos and the educational objectives, and that should do the trick for you. All right. So this is a 28-year-old obese woman presents with chronic pulsatile headaches that worsen when lying flat. She also reports transient vision loss, tinnitus, and diplopia. Fundoscopic exam with bilateral papilledema. MRI brain is unremarkable, and the lumbar puncture shows an elevated open impression of 280 with normal CSF composition. So as you can see, you have every single symptom to point you to a certain diagnosis here. On a real board question, they will pick out a few points here and there, and they just want you to realize. For example, may tell you, hey, 28-year-old obese woman with pulsatile headaches, and maybe now she's having some problem with blurry vision, and then they may go to, hey, what is the initial treatment? So these questions are there to make sure you're able to connect all of these pieces together at once, and don't miss anything. So what is the most appropriate initial treatment for this presentation? Okay, so go ahead and pause the video right here and let's go through the options. All right, so of course the treatment here is acetazolamide based on these options. So let's go through the pathophysiology. So this is idiopathic intracranial hypertension, formerly known as pseudomotor cerebri. It is due to increased CSF production or decreased absorption. The primary risk factor is going to be obesity, and there are other risk factors such as tetracyclines, vitamin A derivatives, growth hormone, and the pathogenesis is really the increased CSF pressure. What it can do is cause optic nerve compression, which then leads to your papilledema and the vision changes that we were talking about. The main concern with these would be a vision loss from a chronic optic nerve damage. Okay, so the question gave you a lot of things. You said the young woman that is obese. It tells you about the headaches that worse when they lay down. Okay, I can kind of tell you about the intracranial pressure elevation, the papilledema, the transient vision loss, and most specifically a lumbar puncture opening pressure that is greater than 250 millimeter of H2O. And the options were corticosteroids. Of course, these are not first line, and they may be they're used short term if rapid symptoms relief is needed. Topiramate, that would be, is a weak carbonic anhydrase inhibition, is less effective than acetazolamide or Diamox for IIH, and so this would be the first line here. But basically, the mechanism of action of the acetazolamide is to inhibit the carbonic anhydrase, and by that way, you are able to reduce the CSF production. Beta blockers are used for migraine prophylaxis, and this one, carotid endarterectomy, would be related to carotid stenosis, and no role here. So, going through the clinical decision making, so you identify the classic IAH symptoms. You can rule out secondary causes, or if you want to rule out cerebrovenous thrombosis, right, with an MRI, MRV of the brain. You can confirm your diagnosis with a lumbar puncture, which also could be a therapeutic, because a lumbar puncture will relieve the pressure, and you can start them on acetazolamide and weight loss treatment. If the vision worsens, we need to probably consider surgical options, which are optic nerve sheath fenestration or CSF shunting. Okay, this would be the more invasive test to do, but again, just kind of make sure that these are always in your memory about IIH. Young obese woman, headache, papilledema, elevated CSF pressure opening at 250, and the first line treatments, and your other treatments, and your guidelines. Of course, this is based on the 2023 American Academy of Neurology guidelines. The MRI, MRV rule out secondary causes of elevated intracranial pressure, including the venous sinus thrombosis, especially in someone with history of OCP use. And the same thing, first sign is there, reduces CSF production, weight loss. Even a 5 to 10% reduction significantly improves the symptoms. So that's very important to know. And the severe cases, what to do. And the high yield takeaways are again re-emphasized and re-emphasized. So this is how we learn: repetition, and put that in your memory. Okay. Take a picture of this scene so you can remember it. All right. Let's go ahead and move on to the last question. If you've been here till the last question, thank you so much for being here. Thank you so much for listening in. Don't forget to like and subscribe. We're going to go over the last question. So, this is a 32-year-old woman. She presents with acute onset lower extremity weakness, flaccidity, and irreflexia. She also reports urinary retention and bowel dysfunction. Neurologic examination reveals a sensory level at T8, and the absent Babinski sign and no clonus. 1 week later, she develops spasticity, hyperreflexia, and a positive Babinski sign. So it wants you to basically tell me which of the following is the most likely diagnosis. So go ahead and pause the video right here, and let's go through options together. All right. So the answer in this case would be transverse myelitis. And this is very commonly, I've seen probably around 4 or 5 of these cases, especially post-infectious at the hospital that I've been practicing over the last 3 years. And they are very, very significant. The results of this is devastating for the patient. So the pathophysiology. Transverse myelitis is a rare immune-mediated inflammatory disorder of the spinal cord. It is commonly happening following a viral infection, at least 50% of time. Based on our epidemiology, the pathogenesis is that inflammation leads to segmental spinal cord dysfunction, causing both, this is very important, motor and sensory loss below that lesion. Okay, so initial phase, you could have something called a spinal shock, where you get the flaccid paralysis, areflexia, and maybe a bowel bladder dysfunction. And as in the later course, you may develop the upper motor neuron symptoms, such as hyperreflexia, spasticity, and Babinski. Okay, so that's very important to know. Depending on when the patient presents, you may have these findings. So very important to be able to really have this picture of a transverse myelitis presentation in your brain when you see a patient with such a neurologic deficits. We always tend to think about, oh, someone flat spastic reflexia, GBS, right? But just remember that there are other possibilities. There are other immune-mediated inflammatory disorders, one of which is transverse myelitis. Okay, and this is the presentation. So the key clues that when you kind of dissect it, the acute lower extremity weakness, flaccid paralysis, initially progressing to spasticity and then hyperreflexia, a sensory level at T8 that's and below, and a bowel and bladder dysfunction. The first option was GBS. Again, they always try to make you distinguish between these two. So GBS causes the ascending paralysis, areflexia, also doesn't cause any sensory loss, right? It's a disease of the peripheral neurons, right? But this is different. Transverse myelitis has a distinct spinal level of sensory loss that you have to know. And MS. So MS typically presents with a relapsing remitting. You have maybe a optic nerve presentation, right? With the color blindness. Does not cause a well-defined sensory level in one episode that's such as this one. Doesn't have a sensory loss, right? As this one. And so it would be different, as you can see. And the transverse myelitis, causing the spinal cord dysfunction and sensory loss, that would be correct answer. Spinal cord compression, for example, let's say tumor, disc herniation, those usually can have gradual symptoms and often have some pain with compressive, and maybe even if it's related to a tumor, it could be weight loss and things like that. Although chronic immune-mediated diseases can cause weight loss, but that's something else. And then myasthenia gravis. So this is a fatigable kind of presentation, although in real life, in practice, would be a little different. You may not always be able to find this fatigability without an EMG, but no sensory loss or bowel bladder dysfunction is usually bulbar signs. Remember that with the myasthenia gravis, okay? And then association with thymoma, and you do the x-ray and things like that. All right, so let's go through the algorithm. So you have a patient with acute to subacute kind of a spinal cord dysfunction, weakness, sensory loss, bowel bladder involvement. They do present with a sensory dysfunction as well, and it could be restricted to a certain spinal cord pathology. The you get an MRI, okay, as your third step with contrast to see those enhancing cord lesions with edema, because inflammation with cytokine release and that pathophysiology bringing more edema into the interstitium of that area. And then step 4, you perform a lumbar puncture, and you will see that the CSF can have mild lymphocytosis, elevated protein, and a normal glucose. There will be similarity in the LP of this one to GBS. They're gonna have the high albumino cytogenic dissociation. That means there's a lot of protein, okay? And the first line treatment in these cases, you basically have IV corticosteroids that you can use, and some points IVIG if needed. So let's go through the pattern. So pattern: acute limb weakness, sensory loss, bowel involvement. Think about that, especially post viral infection, a disease, a neurologic condition that has flaccid paralysis and then turns into a spasticity is another important key clue for board exams. And then finding enhancing spinal cord lesions on multi levels, you can say that could be transverse myelitis, and the guidelines are there. There are also, they did point to plasma exchange if severe cases and do not respond to steroids. And usually about prognosis, they say that they expect recovery in 3 months in most cases. 40% of the patients may have permanent disability, so just remember that. And in terms of the CSF analysis, they do say about the protein and the lymphocytosis, they say there is no oligoclonal bond. So this is another way you can distinguish with MS, which would be very typical for the presentation of oligoclonal bands. The final takeaway is that transverse myelitis with acute spinal cord inflammation, weakness, sensory loss, and autonomic dysfunction can be there. Early, you have the flaccid peritoneal areflexia, then it can turn into a spasticity, hyperreflexia, Babinski sign. Don't forget about the utility of MRI. Don't forget about the IV corticosteroids, IVIG, maybe even plasma exchange. In severe condition, remember that if we don't treat it early, they can have residual disability from this. Okay. All right. So if you stay till the end of the video, thank you so much. I told you I was going to tell you that at the end of the video, you can access these notes on my Patreon. I have the basically summary of all these notes from all of the educational objectives that we've gone through. And basically what you can do with these notes is that you can use the notes to create more questions on the same topic. So you can have your own ABIM board exam questions, and on your instructions you can have it analyze those and create more board questions for you. That way you can be a master at answering board questions. All right. Thank you so much for being here. Don't forget to like and subscribe, tag a friend, let them know. I'll see you on the next one.